Hi, everyone. Welcome to our August ICARE Case Conference. I'm Tua Pal. I was going to start with the first case. As everyone knows, this is a case conference focused on updates on PALB2. So here's the first case. 27-year-old female had genetic testing due to a family history, and then was identified to be PALB2 positive. And for this one, just really thinking about medical management, just to go through this. Here's a 27-year-old. She's got an aunt on through her mother, so a maternal aunt with breast cancer age 51, and then pancreatic cancer in the maternal grandfather. And then on the dad's side, there was an aunt with breast cancer at age 47. I ran the CAN risk estimates, and as you can see, again, with the 5-year and 10-year risk estimates, as well as the lifetime risk estimates, which you can see are pretty high. Usually we don't see risk estimates that are above 60% for PALB2. And then you see the ovarian cancer risk estimates. Again, lifetime looks like somewhere around 5%. I know Marc, our guest expert, often asks about the risk factors that were used to generate these risks, so I've included those. So with that, I wanted Marc to comment on this, but first I wanted to introduce him. So for someone who really doesn't need any introduction, our guest expert is Dr. Marc Tischkowitz, someone we kind of equate with expertise in PALB2 associated risks and management. So he's the professor and head of the Department of Genomic Medicine at the University of Cambridge, and he's established international expert in PALB2. His research interests are broad and include many facets of inherited cancer predisposition. But again, he's been on our case conference other times as well, which we very much appreciate. So Marc would really appreciate your input, and then we will go on to your talk.
Thank you very much, Tua. Thank you for the invitation and for your kind introduction there. So coming back to this case, we don't know where it's come from, do we? So are you able to test the father? I mean, the mother died quite young, so it's a bit uninformative, isn't it?
Yeah, we didn't, I told her that, but we don't have family testing at this point. So we don't know which side of the family it's coming from. You're absolutely right.
And coming back to your risk, I mean, the risk is, I noticed her BMI is quite high, so that would put her risk up.
You want to see this?
I think it looked like it was over 30. So, so if there's something she wanted to do to reduce her risk somewhat, she could focus on that. I mean, having said that, it's not going to make a massive difference, but it gives her some, something to consider. She's not taken the pill before, so that would have been another risk factor. So, and given she's quite young, I mean, you're doing this risk estimate, and so the lifetime risk will be a bit higher. If your average person is getting a risk estimate at 40, you're already giving her a few extra percent just because of the, you're doing this at a young age essentially. So the risk to age 80 does seem a bit scary.
It was just, I'll tell you, I'll be honest with you, this was higher than I'm used to seeing with PALB2 when we're saying all comers, the average risk is somewhere between 40–45%, right? Yes, she has a family history, but we don't know which side it's coming from. It's not a huge family, but it wasn't that striking a family history. So that's where like
too young onset. Well, each side, the breast cancer is a bit on the young side. I mean, I would say it's a dynamic estimate, and I would counsel her to focus on the next 10 years because in 10 years time we'll be doing PRS routinely, we'll be doing mammographic density, something else to consider here. So these whatever estimates we're giving her right now to age 80 are going to be updated. So I would be I'd already focus on the next 5 to 10 years, and that looks quite reassuring. Does she know what she wants to do with her at this point?
No, at this point, she wasn't going to do anything
Mm,
imminently, right?
mm,
But
mm.
would you start the breast screening earlier? Because usually with PALB2, we don't start until age 30. With this kind of risk estimate, that would be my other question. Would we start it sooner?
I mean, we would also probably we've been sort of moving. We usually start everyone at 30, and we've more recently we've been moving down a bit to 25. Yeah, for BSO1 2, PALB2. Um, so I think, I mean, that's a possibility here. I mean, the other thing is, smoking and alcohol, advice on that, given there's some family history of pancreatic cancer as well. So there are some things that she could do herself, reducing her weight, avoiding tobacco, drinking moderation.
Yeah, but how much are those gonna, like breast density,
Well,
I find whenever
yeah, sure.
that really changes things, but I
That's
don't
true. But then often I think psychologically it's quite important to know that there are some things that one can do, that it's not, um, but yeah, you're right. I mean, it's not going to make a huge difference. The risk is
know.
really small.
Would you start at age 20? Like, would you start now with the
I
MRI?
think at 27, that doesn't seem that's not unreasonable.
Yeah, no, I agree.
I mean, we don't offer pancreatic surveillance, so the money I save from that, I would do on extra breast
Yeah,
MRIs.
that's at 50.
Yeah, right.
So there would be a while before
Yeah,
that.
yeah.
Okay.
I think that's reasonable. But
All right.
I think the important emphasis is, focusing on the 10-year risk and explaining this is dynamic. It's harder if she was to say she wants risk reducing mastectomy, because that's more a permanent decision that she's making on this point at this point in time. And again, you'd have to counsel her about that and say, well, this is what we think now. These risks could change quite a lot. There are confidence intervals around them. There's uncertainty. So if you're making that choice now, it is the best information that we have right at this point, but it could be wrong.
Yep. Okay, that's what we did.
Hmm.
And perfect.
Good.
Take it away.
Thank you. Right, we can skip the first slide. The only thing I'd say is my office is being renovated and the builders have all gone home because it's late here. So I'm not expecting any extraneous noises, but I'm not in my usual place. So apologies if there are any interruptions. I'm not expecting any. Okay, next. I'm doing the slides, aren't I? That's all right.
Yeah, you
Yeah,
can
there we
push.
go. Okay, we'll get going. So I'm just going to bring everyone up to speed. I'm aware that some of you may know more about PALB2 than others, but we'll start from the beginning. We'll go through the cancer risks, how we're refining them, the current guidelines that Tu and I wrote together with others. It was an international guideline committee, what the challenges are, and also the resources that are available. I mean, this story for me started when I was in Montreal working with Will Fowkes, and this was back in the mid 2000s, and we were looking at unsolved families essentially. And Will, gave me this family to look at where there was a very strong history of breast cancer in the mother, and tellingly, the daughter had had Fanconi anemia and a nasty version of it with lots of tumors as well. And this had been written up back in the 80s. So that was an interesting family to look at, and we were talking about it, and at the time, this paper came out by David Livingston, who sadly passed away a few years ago now, and was a real giant in the field of DNA repair genes and the discoverer of the PALB2 gene. And he was incredibly helpful to us in working with us with this family, and we did indeed identify pathogenic variants both in the mother and the father. And this is one of the first published reports on the association of PALB2 with breast cancer. And you can see that this explains the mother's strong family history. There is also, a reasonable family history on this side. We were able to trace it back and found out that it came from the maternal grandfather side on that side. So this was really the first case that we studied. Moving on, so that was 2007. Then it took another 7 years to this was an international consortium at this point, come up with the first really good risk estimates. which for the first time showed that this was actually a higher risk gene than had what previously been thought, and then we validated that in 2020. So this is now 13 years since the discovery of the gene. We finally had some risk estimates that we felt were quite translatable into clinical practice, and they are that by age 50, on average, the risk of breast cancer is about 17%, and about 55% to age 80 for someone born in this decade. And then I think what really sealed PALB2 as a high risk gene was this paper that came out by the BCAT group, and there's a sister paper from the carriers group led by Fergus Couch, and this is a case control study, so it's going to be unbiased or less biased than what the studies that we had led on, and you can see quite clearly that PALB2 is associated with a high risk of breast cancer, not far behind BRCA2 there, and mainly ER positive, with some increased risk for ER negative as well. So this paper really, at this point, I think that there's no doubt that PALB2 is an important breast cancer gene. But the interesting thing that we saw when we did our work was that the risks increased with younger decade, with more recent decade at birth. So if for a woman born in 1930s, her lifetime risk of breast cancer was much lower than that in a woman born more recently. And I think that also relates back to the case that we were just discussing, because we expect that this trend continues. And she was born in the 90s, so that may also explain why her risk is higher than we might have expected. We also looked at other cancers. The ovarian cancer risk has always been a bit difficult because it sits very much at the threshold of clinical utility, actionability, and there's quite a wide confidence interval around that as well. And subjectively, we don't see that much ovarian cancer in our PALB2 families. So if anything, this might be an overestimate. Some of the other studies have suggested it's lower, it's around about 3%. I definitely don't think it's up here. So I think it's maybe up to 5%, but in reality, it could be lower than that. So this may well be an overestimate just caused by ascertainment in our work. Likewise, there's a small increased risk in male breast cancer, again, wide confidence intervals, but that would not be unexpected given what the gene does. So I think that would be that is a reasonable thing, and other investigators have also seen reported male breast cancers with PALB2 pathogenic variants. And pancreatic cancer, also a small increased risk, so in a way mirroring BRCA2 but lower than that, and you can see that in both sexes there. And again, we can discuss that a bit later on. It's a bit of a bone of contention what you do with that sort of level of risk, and lifestyle I think can make a quite significant difference here. So as well as looking at other cancers, we looked at variation by family history, and we saw a pattern that's also been seen in BRCA1 and BRCA2, namely that the family history very much influences the level of risk. So if you don't take family history into consideration, or the woman has no family history, then the risks are sort of lifetime risks for just over 50% to age 80. If you've got a mother who's had breast cancer at 50, or maternal so one first degree, one second degree relative, or one first degree very young, that goes up quite a lot. And then two first degree mother-sister breast cancer, you're ending up with quite very high risks there. And we see that for other genes as well, that sort of pattern. And where does PALB2 fit compared to the other genes? Certainly BRCA1 and 2 are way out there, and PALB2 is sort of the third gene. It's definitely nearer BRCA2, and not so near CHEK2 and ATM essentially. So it's definitely the third important gene in this group. And it gets more interesting than that because these risks can be modified, and once you start adding in polygenic scores, and you increase the the range of risks, you can see that there is really quite an overlap between the higher end of PALB2 and the lower end of BRCA1 and BRCA2, and also some overlap at the other side as well. But it does sort of, it's quite clear that it does sort of sit in the middle between the BRCA1 and BRCA2 and the moderate risk genes. It's almost by itself there. So in terms of tumor characteristics, we know that there is some enrichment for triple negative breast cancer. You can see, like, this is the risk. The rate is about 16% for someone who's not got any pathogenic variants, and you can see it's a bit higher for PALB2, very similar to BRCA2, and BRCA1 is well off the scale there, essentially. So, so there is some enrichment for triple negative, but the majority of PALB2 breast cancers will still be ER positive by a long way. So in a way, you can think of these tumors very much like BRCA2 tumors. I think this is a newer one of the more recent bits of information, which I think is quite useful to know. And you can see that this is basically looking at various studies like the BCAC study, the Bridges study that I talked about, the carrier study, and biobank data, and combining everything together and looking to see, what are the actual figures of the frequency of these genes in the population and also in unselected breast cancer. And you can see that of these three genes, in fact, PALB2 is more frequent. There are more carriers in the general population than there are for BRCA1. But the percentage in breast cancer is a bit lower, and that's because the penetrance is lower, essentially. But if if you just tested anyone in the general population, you'd actually find more carriers. And it's interesting, why is there so much less known about PALB2? Why do we have fewer carriers than BRCA1 and BRCA2? Partly this is the penetrance thing, but the main answer will be it's historical. We didn't really start testing for PALB2, until maybe the early mid 2010s, whereas BRCA1 and BRCA2 have been tested for since the mid 90s. So we have 15 years more worth of testing for these two genes than we do for this one. So I think that's the main reason why these, and also the amount of research that's been done on these two genes is because of this leap in in knowledge over those 15 years. So that if PALB2 had been identified at the same time as BRCA1 and BRCA2, I think we'd always see it. We'd always put these three together. But because of history, I think it's taken us longer to really link those three genes and put them in a separate category to the other genes in this slide. And you can see RAD51C and D really very account for a very small portion of breast cancer. CHEK2 and ATM sort of annoyingly in the middle as ever, and then you've got the the very rare genes as well. But I think that just really shows you where PALB2 sits in the overall landscape of breast cancer genetics. So what do we know so far? What we said? Well, we know that PALB2 pathogenic variants are associated with a high breast cancer risk. We know that the relative cancer risk decreases with age. So the older you get, the less influence the gene has, and that's the same for BRCA1 and BRCA2 as well. We know that the relative risk increases with the more recent birth cohorts, and we know that there are associations with other cancers like ovarian, pancreatic, and male breast cancer, although these are very modest associations. And we haven't seen a clear association with colon or prostate cancer. Interestingly, there are some data that show that prostate cancers in PALB2 carriers are more aggressive than those in non-PALB2 carriers. So it could be that this gene is having some effect after the actual cancer's been after it's been developed, but it's unclear whether it doesn't feel like it's likely to be a strong prostate cancer predisposing gene based on the data we have at this time. And I think there's no BRCA3, but if you're looking for one, then this is going to be the best candidate. And we know that there aren't any other genes that are going to be discovered that are remotely as frequent or as penetrant. So going forward, that could be it hasn't really taken hold, but that's not an unreasonable suggestion, I think. And also, I've said this before, but we do need to move away from the moderate risk term, showing that and it's really coming down to the the individualization of risk, as I showed you, once you start adding in things like polygenic risk scores. So I'm just going to briefly go through the guidelines that Tu and I wrote. This is several years ago now, but I think they're still valid and to the point. And the key recommendations were: it's important to use personalized risk estimates such as CAN risk to guide clinical management. And I'm pleased to see, I think all the cases we're discussing today will fit into that. And generally, we feel that PALB2 individuals should be offered similar surveillance to BRCA1 and BRCA2, and modify according to individual risk. And risk-reducing mastectomy is a reasonable option. Again, it's really a shared decision making with the individual involved. So I don't think, and none of that seems to stood the test of time over the last few years. It doesn't seem particularly controversial. Everyone's accepted that. And by personalizing the risk, you can, if you just take the point estimate that we've talked about before, which is just over 50%, what you can do by adding in lifestyle factors, this is questionnaire risk factors, so things like height, weight, menopause, menarche, you can spread out that risk a little bit. And what you want to do is make that curve as flat and as wide as possible. That helps you a little bit. Adding in mammographic density, which is this line here, and it gives you a bit more precision, individualization. And then once you add in a PRS, you can get a nice flat curve, which really then shows you that the true spread of risks that can be individualized for an individual. And this is a 20-year-old with a PALB2 pathogenic variant. And the way to do this is using CAN risk tool, which I'm assuming you're all fairly familiar with. I'm part of the team that has developed this, and we're always welcome to have feedback from you, because it's through your feedback that we continue to improve it. Many of you ask us, when is the patient-facing version going to be available? I can say that it's pretty imminent. We're doing some beta testing on it, and it looks pretty good. So I think that will be the next exciting new development when it comes to CAN risk. So if you take a family, this is just an example family, someone who's in their 30s, who's got a PALB2 pathogenic variant, inherited from their mother who had breast cancer at 48, and there's a pretty strong family history there going back up to the grandmother. You can see that in this individual, without PRS, her risk, as you'd expect, would be quite high because of that family history. And then once you start adding in a higher, if, for example, if she had a high PRS with a higher Z score here, then that would, boost that risk further still. And it also changes, I think importantly, it changes this end of the curve as well. So it's not just about the overall risk, but it's about the risk here, which may help guide decisions about when to have risk-reducing mastectomy, for example. Conversely, if she had a low PRS, then this risk would drop down quite a lot. And again, she could defer risk-reducing mastectomy until she's quite a bit older, if she was in this category. So you can do something similar with an where there's no family history, essentially. So again, you can sort of modify these risks somewhat, based, and you can see that family history perhaps doesn't make such a big difference compared to the actual PRS here. So PRS is probably more useful than the family history itself. And we've been exploring this further. We've been running a study in the UK and also the US in Stanford called Precision HVOC. And this is the team here. What we've been doing is looking at women who've undergone predictive testing for genes linked to breast and ovarian cancer, so BRCA1/2, PALB2, CHEK2, ATM. And we've randomized it. So we have a control group where they get where they haven't where they just have standard predictive testing and their results, given their results. And then we have a study group where they also get predictive testing and they get the PRS added in. And we've been looking at what the impact of this personalization is in terms of decision making, levels of anxiety and worry and acceptability. We've just closed the study to recruitment. We've recruited 600, just over 600 women, and we will be going forward. There are some questionnaires that these women need to fill out. So I think the data should be mature sort of mid next year, and then we will be publishing those results. I think from what we've seen so far with other similar studies is that the PRS really makes the big difference in the more moderate risk genes, and less so in the BRCA1 and BRCA2 because the risks are so high there anyway. So the real areas where they are useful is in CHEK2 and ATM, with some use in PALB2 as well. And this is the sort of type of report that we've had. So where we've been doing the polygenic score, and then we get this Z score that you can enter directly into CanRisk to refine the estimates for your patient. Contralateral risk-reducing mastectomy is quite controversial, and we were fairly diplomatic about what we said in the guidelines. And I think when you're using CanRisk, I think this is one of the areas where there is the least amount of certainty, because we don't have very good data for PALB2 and contralateral risk breast cancer. So a lot of so many assumptions are made when those risk estimates come out. And most importantly, we don't take into account treatment effects such as tamoxifen or aromatase inhibitors, which could quite significantly reduce those risks. So I think, be very, very careful when you're using CanRisk to calculate contralateral breast cancer risk. That's definitely the weakest component of the current CanRisk program. I think you just need to take a certain amount of clinical judgment as well, and don't be too fixed on the percentages that are given. So this needs more work. There were some studies from the BCAC and the Bridges and the Carriers group suggesting that actually the risk of contralateral cancer may not be that high in PALB2. And there's some speculation that this might be because the cancers are mainly estrogen positive, and many women who've had an estrogen positive breast cancer will then go on to have endocrine therapy, such as tamoxifen and aromatase inhibitors, and therefore prevent a second breast cancer. But even though those studies, those studies are actually based on quite small data points. So I think, again, one has to be fairly cautious about it. And I think that overall, at the moment, I think CanRisk probably overestimates the risk estimates, particularly if a woman will be taking endocrine therapy. And this is an important situation because it's often, this is often used to guide, additional surgery, which carries its own risks. Ovarian cancer is also controversial because it's the risk here sits right on the cusp of actionability. We don't offer surveillance. There's no real need to do risk reducing urophorectomy under the age of 50. It could be considered above that age, but I think if there are any surgical risks, if there are a comorbidity, for example, then it may not be beneficial for the woman to go down that route, given the overall low lifetime risk of ovarian cancer. And just to emphasize that, this is where sort of PALB2 sits compared to other genes. It's right at the sits right on the threshold of benefit. So it's fairly neutral, and this can make for fairly difficult counselling. Pancreatic cancer, I think this is one where there is quite a lot of difference in management according to national guidelines. And in the UK, we've taken a fairly conservative approach based on the limited evidence that it actually reduces mortality. And therefore, we're not offering this routinely to our patients. They can enter a research study if they have a family history of pancreatic cancer, but otherwise we do not offer them any surveillance options. I think therapy is really interesting, and it's clear because PALB2 is so similar to BRCA1 and BRCA2, works in the same pathway, similar phenotype. It wasn't really a surprise that it also responds well to treatments such as the treatments that work well in BRCA1 and BRCA2, such as PARP inhibitors, and you can see that quite clearly here compared to CHEK2 and ATM. But it tends to get left out of studies, and I think there needs to be a concerted effort to always include PALB2 when there are trials going on looking at BRCA1 and BRCA2 patients. Because as I pointed out before, they're at least as common as BRCA1 and BRCA2 in the general population, but they're just they're very much treated as a third, as less important. And I think that's exemplified. But this is an amazing study on BRCA1, BRCA2, showing the the benefit of olaparib in adjuvant therapy. And and on the back of this, olaparib has been licensed in this use in BRCA1 and BRCA2 carriers, but PALB2 carriers were not included, and it's unlikely that a similar study will be done of that scale and size for PALB2. So we're left in this sort of difficult situation where biologic, on many levels, it makes sense that patients who have PALB2 pathogenic variants should be offered the same treatment options as BRCA1, BRCA2, but we don't have the the strong phase 3 evidence that there is for BRCA1 and BRCA2. So you get pushback from insurance companies and healthcare providers on this. Just finishing up with a look at prognosis. This was an interesting study done by Alison Kurian's group, where they looked at is there any difference in outcome in a variety of different cancers in individuals with a number of different well-known genes, including PALB2, and it was clear that really the outcomes are very similar, or there's no difference really there's no statistical significance difference in triple negative breast cancer or in ER ER positive breast cancer. So it seems that the prognosis is not any different to wild type, to breast cancer in someone who doesn't have a pathogenic variant. And in terms of where things are going with this, we have over many years collected together quite a large number of families through the PALB2 interest group, and more recently through SIMBA Plus, which is a consortium based on, SIMBA has been around since the early 2000s, developed initially by Georgia Chevenix-Trench and Doug Easton and Anthony Santonio, and has been highly successful for BRCA1, BRCA2. More recently, it's expanded to other genes, including PALB2. And in a relatively short period of time, there's already quite a large number of individuals that have been recruited to the studies making up this consortium. And in the UK, we most recently have also developed a national cancer susceptibility registry, where we are collecting together all carriers for these genes in a sort of public health setting, and that's turning out to be quite beneficial as well, although that's still at an earlier stage. So just to finish, we do have some resources as well. We have a website. Unfortunately, that was down for about a year because we had quite a nasty cyber attack, and it actually is a little bit out of date. I haven't quite got around to updating it yet, but I will be. We've refreshed it a bit, made it look a bit more modern, but there are things I need to do with that. Also, we have a patient leaflet that's downloadable from there. Again, I'm working on an update. This was written in 2021, so there'll be small updates to that. There's a big Facebook group, and we do patient information sessions, usually about once a year, essentially for an hour, and these are all available on YouTube. And I have to thank my Yulia Bainham, who is the patient partner for a lot of the work that I do in PALB2. And as well as thanking her, I've got to thank Antonis and Doug as well for all their help. And I've put some links here. You should all know that one. This is the PALB2 one. Do click on it because it used to be the #1 link, and it's because it was out of action for a year. It's sort of fallen off the top page. So if you want to do me a favor, go and search it and click on it, and hopefully we can get it back to where it was before. And that's my email address if you've got any particular questions. And thank you very much for your time.
Thank you, Marc. That was fantastic, as always.